Good afternoon. I'm going to be talking today about the psychology of eating disorders. There are different kinds of eating disorders. Without going into too much detail about each of those, anorexia usually includes a significant concern about gaining weight and restriction of food intake leading to low weight. Whereas in bulimia, the restriction of weight is usually through inappropriate compensatory behaviors when there are binge eating episodes. The difference between anorexia and bulimia is often the body weight, which is much lower in anorexia. There's also another category of avoidant or restrictive food intake disorder, which differs from anorexia simply with the condition that there is not much concern about the body weight or shape. And binge eating disorder, which is also very similar to bulimia, but does not include the compensatory behaviors that are usually part of bulimia. There are a number of psychological factors that may be associated with eating disorders. So these are in general across different theories and conceptualizations of eating disorder. One big one is powerlessness or a feeling of helplessness, a lack of control over one's immediate environment, over one's own life. Perfectionism, which can become dysfunctional and obsessive to an extent. Rigidity and inflexibility in one's personality, low self-esteem, and often self-esteem derived from one's body shape or appearance or body weight, extreme sensitivity to criticism and need for approval, impulsivity, more often in the case of bulimia than anorexia, negative early feeding experiences in infancy, a history of childhood adversity, abuse, or trauma. This is something that is common to many eating disorders. Often a chaotic family. Again, this is more common in bulimia than anorexia. Critical family, which seems to again be common across eating disorders. A lack of warmth in family communication. Poor awareness of emotion, that is not being able to recognize what one is feeling, which is also called alexithymia, and poor ability to regulate the emotion, along with poor coping styles. So for instance, if I'm feeling sad, I may not even know that I'm feeling sad. I may not know what to do about it. If, for instance, most of us would call a friend or do something else that would make us a little happy, or even just tolerate the sadness, knowing that it's going to go away soon. But people with eating disorders may have a very poor ability to do that, to tolerate negative emotion, to sit with it, or to talk about it, to reach out for help, or to do something adaptive instead. They may use eating as a way to make themselves feel better. Another, as I'm sure all of us know, is social and media models of thinness and beauty consisting of a perfect body shape, etc. So there are a number of these factors which seem to be extremely interrelated, and we have to get very complex ways to produce what we see as eating disorders. One of the theories, so what I spoke about so far were, like I said, across theories, but there are also some specific theories, psychological theories, which try to explain why of them is attachment theory. Now, this is used to explain a number of different kinds of psychological conditions. Attachment as being either secure, and in secure attachment, what we often see is a responsive carer who is sensitive to the child's signals of distress. And every time the baby cries, the mother responds in an attuned, sensitive manner. And this helps the baby develop this feeling of, I'm lovable, others can be trusted, they will be there to help me when I need it, and what I feel makes a difference, what I feel matters. Whereas with insecure attachment, often children may not get this signal from the mother. When they're crying, either the mother may not respond at all, or may respond with anger, try to get them to shut up in a sense, etc. And not just the mother, it can be any carer, but most often it is the mother. So when feeding, early feeding experiences are accompanied by mother being impatient, the feeding becomes a substitute for attention. So every time baby cries, all the mother does is feed, and that will result in a cycle of pseudo demand and overfeeding. So whenever the baby needs attention, there's crying, demand for food, and that's what is met. This may become a way to get attention from an unpredictably responsive carer, and may perhaps pave the way for bulimic type behaviors. Another pattern is when the mother is completely unavailable, completely ignores baby's cries for extended periods of time. So with most of these, we're not talking about once or twice when the mother's a little impatient, because all mothers can feel like that. But we're talking about a pattern of extended periods of time. This is the same pattern that goes on. The mother's, for instance, unavailable in the second instance, and the baby over time learns that there is no point trying to seek out the mother's attention, avoids seeking closeness with the mother, and may even avoid feeding. And this may lay the stones for development of anorexia, particularly the restrictive type later in life. But the relationship is by no means so simple. This is just a hypothesis of this is how it might be. So although attachment is known to predict eating disorders, exactly which pattern and how is still not very, very clear. But there are a number of other perinatal factors that may play a role as well. For instance, having a difficult birth experience for the mother, parental discord, and if there are early difficulties with breastfeeding for an extended period of time again. All of this may lead to the mother being more ambivalent or negative towards the baby. So psychotherapy from an attachment perspective usually focuses on establishing a secure base in therapy between the therapist and the client, and validating more appropriate ways of communicating distress, so that the inappropriate ways, that is eating in order to relieve distress or avoidance of eating to feel a sense of control, slowly fade out over time. They are no longer required because there are better ways of communicating distress, which is understood in therapy. Another model is the cognitive behavioral model. Now, the core aspect of cognitive behavioral models is the interplay between thought, emotion, and behavior. So it is understood that all these three are very closely interlinked, and that they play, that they're constantly interacting with each other. So in cognitive behavioral models, we understand that there are certain core beliefs which are formed through early childhood experiences most often, and the immediate family, etc. So some examples of core beliefs might be, I need to be thin in order to be loved, or thinness equals perfection, things like that. There are also what we call cognitive distortions, which are basically biases in processing information. They are how we distort reality. And many of us may do it often in many ways, but again, we're talking for it to be dysfunctional, it goes on for an extended period of time, and it's inflexible. The person cannot think in any other way. So these are some examples. For instance, someone who feels that I've put on 2 kgs, then concludes immediately that I'm fat and ugly and no one will marry me. So the putting on 2 kgs might be a reality, but the conclusions that are drawn from it are obviously distorted. So there is a bias in concluding that I'm fat and ugly, no one may ever marry me, and so on. So many people with eating disorders may have such cognitive distortions which they resort to almost all the time. They're inflexible, they don't, they're not easily changed. So in cognitive behavior therapy, the focus is on both the cognitive aspects as well as the behavioral aspects. So some examples include operant conditioning principles. I'm not going to go into that in detail, but basically it is about rewarding or reinforcing desirable behavior and not rewarding or withholding rewards from undesirable behaviors. So increase in weight, reduced binge purge episodes are often rewarded with, sometimes it could be a star chart, it could be points, it could be other kinds of rewards that the person likes, for example, extra TV time or something else that the person finds pleasurable. The cognitive aspects include a thought mode diary, cognitive restructuring, and learning to understand the link between thoughts, emotions, and behavior, also called cognition, affect, and behavior. And behavioral experiments, which are ways to test things out and see whether it's actually true. So we test out the dysfunctional cognitive beliefs, the distortions, in an actual real life setting. So if your jeans feel a little tight, could it simply be because they've shrunk a little bit after being washed, right? So these are ways to test out whether the belief that they hold is really the one true thing, or there could be other versions of reality as well. So this is a little bit about cognitive behavior therapy. In addition, other things that are done are education about diet, body weight, anorexia, for instance, or any other eating disorder. What is also called motivation enhancement, because often when clients come to us, they are not really wanting to change. So they may be in what is called the pre-contemplation or the contemplation stage. That is, they don't feel like their eating is a problem, or they think, yeah, maybe there is a problem, but I don't really want to do anything about it. And unless they can move forward into wanting to do something about it, taking active action about their eating disorder, there's really not much that can be done in terms of therapy. So a large part of the therapy may actually consist of trying to get people to be motivated enough to work on changing their behaviors. Other techniques that are used are diet management, cue exposure, allowing themselves to be exposed to certain kinds of foods without feeling an uncomfortable sense of fullness, or without feeling disgusted, or feeling the urge to purge, etc. Self-monitoring, eating mindfully, being completely present in the moment, using all the 5 senses to enjoy each mouthful, and also trying to gain control using specific strategies. Another kind of therapy that is often used in eating disorders is what is called body image therapy. The focus is on specific concerns that the person has about body image. So they usually maintain a diary about their beliefs, about how their concerns about body weight, their behavior, restructuring, which is again changing one's thoughts about image and self-worth, very similar to what is done in cognitive behavior therapy. And again, exposure, that is, exposure is basically in a hierarchical way encountering the distressing aspects of one's own appearance. So if somebody feels that there's a certain part of their body that they can't bear to look at in the mirror, it may be a process of gradually getting them to face up to it and regulate their negative emotion about it. So this again is one kind of therapy. Also, like challenging self-talk and preventing body checking behavior, because this is something that we see very often in people with an eating disorder, that every mirror, every reflective surface they pass by, they're constantly checking themselves, and monitoring their body weight or their shape. So trying to reduce or prevent that as well. So all of this is part of body image therapy, where the focus is on body image. Another style of therapy is interpersonal therapy, where the focus is on one's own self-worth and the modification of interpersonal problems, because a lot of individuals with eating disorders may have difficulty with establishing interpersonal relationships, being comfortable, feeling that other people are trustworthy, making requests, and so on. I'm going to talk a little bit more about later on. And in addition, things that are common across different styles of therapy is working on dysfunctional perfectionism, because a lot of individuals have this feeling that they are just not good enough. So therapy would focus on being able to accept imperfection, because we are all imperfect, and that is just a fact of life. And getting people with eating disorder to accept that itself can be a huge challenge. Working on their self-image and self-esteem, so that they are not constantly evaluating their self-worth based on how much they weigh, or what their body shape is like, or what their appearance is like, so that they can find other ways to derive a sense of self-worth. Also being able to find meaning and purpose in things outside of weight, finding a hobby, finding something in work that may be meaningful, or meaningful friendships and things like that. Often what is required is family intervention to manage family dynamics, over-criticality in the family, because this is also something that is quite common across different eating disorders. Powerlessness, which I mentioned earlier on, is another significant factor in people with eating disorders. So one of the ways is to enhance their coping styles, problem-solving training, assertiveness training, improving the communication skills, negotiation skills, and so on. And another aspect is relapse prevention as well. So all of these may be common regardless of the style of therapy that we may be choosing. Now, I'm just going to talk about a young lady who I'm going to call Monica. That's not her real name, and I'm not going to be disclosing any other identifying details about her. So with her, she had anorexia of the binge purge subtype. And in addition, there was a lot of lying, stealing, compulsive shopping associated as well. So to begin with, we decided as a team that we would go in with an open, honest approach with her. The focus would be on trust, on getting her to trust us, as well as making sure that she knows we trust her. So we completely discouraged the family from making complaints about her and that sort of thing, or if anything was brought up at all, any violation of hospital rules, they were discussed with her in an open, gentle way, so that she could tell us if she had any binge purge episodes or anything else like that. That was a primary sort of mainstay of the intervention. In addition, we started a food, thought, mood diary, where we look at the links between what was happening, what the situation was like, what did she eat, what were her thoughts, how was she feeling at that time. And as when we first started this, she was not able to make any connection at all. So often what she would report is that there would be some sort of negative experience. So either she might be bored, or there might be some sort of shaming experience from the family. They pass a number of critical remarks about her. And then she would straight away eat. So that's all she was aware of initially. She couldn't see anything in between the two. But as she maintained this diary for some time, she was able to recognize that in between the two things that happened outside, what she was feeling inside was a lot of intolerable negative emotions. So she would feel extremely ashamed of herself. She would feel sad, angry, frustrated, and that would cause her to binge and purge, and that would in turn lead to more shaming and ridicule from the family. So once we were able to establish this link, it became easier to help her to deal with her emotions in other more adaptive ways, learn to cope in other ways, identify what she was feeling, and figure out what could help her feel better. We also discovered that she was extremely talented in cooking, in craft, sports, dance, and these were not really recognized or praised or rewarded by her family. So a lot of the work was on creating mastery experiences for her to help her find other ways of finding meaning and purpose. We also did a lot of family intervention, family psychoeducation to work with the family because, like I said, there was a lot of shaming and ridicule about her eating behaviors, as well as other aspects of her life as well. Her interests were not validated. She had very complex relationships with her father. He was a perfectionist, but she was also extremely impulsive. She wanted to please him, but also felt impulsive and unable to control her impulses. And there were systemic interventions to regulate the power balance within the family as well. So this was a really sort of intervention that we put together for her. She improved significantly at the time of discharge and was able to take up something that she really enjoyed doing. So this sort of brings me to the end of what I wanted to say today in terms of eating disorders, the fact that there are different types, that there are a number of psychological factors which may contribute to the development and maintenance of eating disorders. There could be personality variables, there could be early childhood experiences, there could be factors within the family, problems with recognizing and expressing emotion. There are a number of different theoretical models that try and understand these behaviors, and there's also therapy which is based on these different models. But essentially, what is really required is a tailor-made approach for each individual to try and figure out different aspects of their lives which may be contributing to eating disorders and how we can intervene with each of those, because just intervening with the eating is not enough. The symptoms may temporarily reduce, but they won't go away because the eating is serving the purpose of, allowing the person to regulate their emotion in some way, because otherwise the emotions would be too intolerable, or there are so many things which are outside of a person's control. So the eating becomes a way to manage all of these other things. And unless we can bolster that, unless we can find other ways for the person to cope with the negative events or their negative emotions, the eating is unlikely to go away completely. So that brings me to the end of my talk.